Very nice introduction, and I thank you also for the invitation to this very nice symposium, which is you are holding in Dubai. So my talk will be about for 20 minutes, and my topic is optimizing treatment of early stage mycosis fungoides. I hope everybody can hear me and see my presentation. So, if you are dealing about mycosis fungoides is the most common type of cutaneous lymphoma. So more than half of all cases of cutaneous lymphoma are mycosis fungoides. It's the most common type of cutaneous T-cell lymphoma. The preferential localization is on nates and other shielded areas of skin. It has usually an indolent course. It's for years to decades with a slow progression from patches to plaques to tumors. This is a very important information, especially if you deal for the first time with your patient and to have to inform him about his cancer, that you also have to spend a lot of time to make clear for him that it is cancer, but has an indolent course, and especially in the early stage, they are living nearly like other patients without cancer. And this is based that development of nodule in case of lymph node or visceral disease is only in a minority of patients. Therefore, the 10-year overall survival and disease-free survival is about 62% and 71%. Before starting treatment, of course, you have to define, after the diagnosis of mycosis fungoides, the stage of the patients, and we have here early stage with T1, T2, and advanced stage with tumors is T3 and T4. And T1 is based on clinical stage 1A. The patients have patches or plaques. If it's only 1A, it's less than 10%. If it's stage 1B, it's more than 10%. And usually the patients have no other involvement, lymph node or organ or blood involvement. And stage 2A means patients with patch or plaques which have a clinically enlarged lymph node, but without histological clear involvement of the lymph nodes. So early stage mycosis fungoides is stage 1A to 2A, and nearly the most often type of mycosis fungoides we are dealing with are early stage. So about more than 70% of all patients with mycosis fungoides are having an early stage of mycosis fungoides. Here see some clinical examples on the left. It's stage 1A is patch and plaques, less than 10% of skin involvement. And the risk of progression to systemic disease is very low. It's less than 5% in this early stage. And therefore, the 10-year survival is about 97%. So it's nearly the same as any other patient without cancer. If you have stage 1B, it's patch and plaques more than 10%. The risk of progression to a systemic disease is a bit higher, it's about 15%, but the 10-year survival is about 83%. Whereas in the advanced stage, in the tumor stage, the progression to systemic disease about 40%, and the 10-year survival is really reduced. But we are speaking today only about the early stage mycosis fungoides. Of course, early stage can do a lot of problems. Also, the plaque stage MF may become extensive. But very important to know, and especially in the Gulf region, is that we have also variants of mycosis fungoides besides the classical one, like here you see on the left foot the hyperkeratotic, or you have the hyperpigmented or the hypopigmented, poikilodermatic MF, or also the elastolytic mycosis MF. It's very important to know these variants because the diagnosis in the early stage is usually difficult, and that's the reason why it usually takes about 3 years. Here you see the results of a large European study, the time to diagnosis in the early stage, and it usually takes about 3 years to define the first diagnosis. Important to know for the treatment, but also if you consider the overall survival, if we speak about 97% or 83%, most of the patients have a middle or advanced age between usually 50 and 80 years, So even 60-year-old patient has a 10-year survival rate of more than 90%. It's something like normal patients without any cancer. And regarding the comorbidities, of course, in this age, you find often patients with diabetes, with hypertension, and other diseases taking a lot of drug. And this you have to take in consideration if you give systemic treatments. Coming now to the treatment. We have different guidelines. We have the British guidelines, we have the European guidelines, which I'm writing with. I'm a member of this guideline. You have the NCCN of the United States, and you have the British one as mentioned. But regarding the guidelines, the recommendation for the treatment of MF, especially the early stage, are nearly the same. So you have the differentiation, especially in the early stage, from skin-directed therapy to addition of systemic therapy or third-line options like clinical trials or treating like patients in advanced stage. And I will go now more in detail regarding the treatment and try to give you some practical ideas how to improve the treatment in this early stage. And you see in this schedule that the phototherapy, especially in the early stage 1A till 2A, phototherapy is still the recommended first-line treatment in early stage mycosis fungoides. So there has nothing changed. But in addition, you can give systemic treatments like retinoids, interferon, and as a novel alternative, we have topical clomiphene as a topical chemotherapy, which I want to go here more in detail. So, coming to the first-line treatments in early stage are still skin-directed therapy, and this is based on, since the lesions are very superficial, and you see in the right the histology. So the infiltration of the atypical cells on the upper dermis with epidermal tropism in the epidermis. So it's very superficial, and with this, they could be reached by skin-directed therapy. So what treatments we have for skin-directed therapy? We have the localized treatments like the topical steroids, which is our first line. We have the topical clomiphene gel, which is a topical chemotherapy, is also first line. In localized lesions, you can do superficial radiotherapy. And for the whole body treatments, of course, phototherapy, UVB. Typically, we use here the narrowband 311 nanometer or the standard PUVA. And as an alternative, I will introduce it at the end of my talk, you can also use low-dose total skin electron beam. So if you see for the first time such a patient, you have only patch and some plaques, so it's mycosis fungoides stage 1B. You have a lot of different treatments. Which can you use? Topical corticosteroids, clomiphene gel as a topical chemotherapy. In some countries, you have also topical retinoids. And you combine this with light therapy, you have UVB PUVA. You can combine it also with systemic treatment. But PUVA alone is still an excellent choice and still the first recommendation in this patient with early stage mycosis fungoides. And as an alternative, if you don't have PUVA or the patient is too old, is not able to stand long time, you can also narrowband UVB phototherapy is leading to also nearly the same clinical response, but PUVA delivers a more deep response. So we have longer disease-free survival if you are using PUVA compared to UVB. But UVB works well. And as already mentioned, as a novel treatment, you can use clomiphene gel, which is also the first-line treatment and approved for all stages of mycosis fungoides. What is clomiphene gel? It is a topical chemotherapy, is an alkylating drug, which intercalates between the bases or nucleotides, and they are then linked. And based on this linkage, you cannot open the double-strand DNA to have a mitosis, and this is the reason why the cells are getting in apoptosis and dying. So in the approval study, clomiphene gel was used for early stage mycosis fungoides, was a phase 2 trial, and the response rate was about 60%, in this early lesion, and measured with the M-SWOT, it's about 15%. There were no drug-related severe adverse events. However, skin irritation is a common adverse event. I will go for this more in detail. So we are using now it since several years, about 3 to 4 years in Europe and in the States. And so if you look for what stage our colleagues are using it, so all of them are using it mostly in the early stage, but some colleagues use it also in the late stage. But when they use it in the advanced stage, they combine it with a systemic treatment. And response is usually seen about 1 to 2 months. You see the usually very good response, and the best response you see about half year to 9 months. And the important issue to know for the doctor and also for the patient is that dermatitis is common in about 20 to 30%. And this dermatitis you see on the right picture, you see when you start the treatment, you have early stage mycosis fungoides, and then you see within 3 months a clinical picture which is more worse than the beginning of the treatment. And this is usually patients and doctors are afraid of this. And the increase of the size of lesions is usually to an allergic or toxic reaction to this clomiphene gel, and it's the dermatitis. And however, after you see here on the 9 months, in nearly all cases of this early stage, the lesions are much better than the early stage. So nearly all patients are getting a partial remission, and also some patients are getting complete remissions. However, this dermatitis is doing often headache for doctor and for the patient, and leading what you see in the table often to a treatment stop or to a treatment break. And that's the reason why we are in the German-speaking countries. We made a consensus meeting, so Germany, Austria, and Switzerland, and discussed where it could be best used, this clomiphene gel. And recommended it could be used for generally for mycosis fungoides, or patients who have severe pruritus, or patients who have steroid phobia, or patients who had already a lot of phototherapy and who are afraid of secondary skin cancer. However, you have to take attention if you use it in sensitive areas, such around the eye or the mouth region as an example, or in skin folds. And recommended use it not every day, as it was approved initially, but use it in an as an interval therapy. So we give on one day, we start with clomiphene gel, and give on next day a topical corticosteroid, which is also a first-line treatment in early stage mycosis fungoides. And by this, we have much lesser the risk of dermatitis, and we can go on with the treatment. And on the other hand, we have also an additive effect, since both treatments, topical corticosteroids and clomiphene gels, are first-line treatment in early stage mycosis fungoides. Here's one of my patients as a clinical example. He has folliculotropic mycosis fungoides, and you see he had only mild irritative dermatitis, and then he got a very good partial remission after 4 weeks. And maybe another important information for this drug, this patient is a cardiac transplant patient, and he's immunosuppressive. And it's important to know that clomiphene gel, although it's a topical chemotherapy, it doesn't show any resorption. So it doesn't show any systemic effects. And this is important also for this patient who are immunosuppressive, or also patients where you combine it with other systemic treatments, like methotrexate in this patient. You see before treatment and after treatment. It's possible to combine it also with systemic treatments like interferon, retinoids, or methotrexate. So what if the skin-directed therapy are not sufficient? And this is very often a problem. And for this case, regarding the guidelines, and of course my personal experience, it's very good to add a systemic treatment to the phototherapy let me say, bexarotene with PUVA or interferon with PUVA. So I want to show you the current data about this combination. Interferon alpha, I think everybody knows it. It enhances anti-tumor host immune response by promoting cytotoxic T cells. It increases the Th1 response. And the interferon alpha, you give it 3 times a week. And the response rate in the early stage is about 88%. And this is very high. And you can combine it very good with PUVA. And by this, you can reduce the cumulative dosage of the UV therapy. Unfortunately, the interferon alpha is not more available. It was discontinued. But we have as an alternative the pegylated interferon alpha, which has a longer half-life. That's why you give it only once per week. My recommendation is to give it only the low dose, 100 micrograms per week, or you can give also the 90 micrograms per week. But I do not prefer to give the high dose of 360 milligram because I have a lot of side effects like fever, like flu-like symptoms. And the problem is since it's pegylated, it works long, but also the side effects are working long. That's the reason why I prefer to give it also as a low dose, 90 or 180 micrograms once per week. And by this, we have good experience. And here we see a recent study published a half year ago. And it shows not only that you have a high response rate, but it shows also that it improves the overall survival of these patients and also the disease-free survival, especially these patients who had complete remissions. So interferon alpha has a very high response rate of 88%. It's an ideal combination with PUVA, and by this you can enhance the response and also the prognosis. The other possibility is to combine the phototherapy with retinoids. As an example, bexarotene, which is approved for cutaneous T-cell lymphoma. And here also a very recent study, which it's a meta-analysis of all published data, and it shows in combination with the phototherapy, typically PUVA, it has an overall response about 65%. So it's a bit lower than the interferon, but it's still very high. It's an interesting combination. However, with bexarotene, we have always to consider that you have to give at least in addition 2 other drugs. So you have to give always, due to the very common hypertriglyceridemia, a lipid-lowering drug, and you have also to substitute thyroxine because nearly all patients have hypothyroidism. And it could have other side effects like liver toxicity, neutropenia, and anemia, which is not so common. But nearly all patients are getting elevation of lipids and hypothyroidism. So the question is, what about other retinoids? Is this possible? And the answer is clear, yes. As an example, I want to show you just one study. Alitretinoin, you can give it in a dosage of 30 milligrams, 1 capsule per day, and you have also a high response rate. And you can combine it with PUVA. So if you want to, and here you see an older study where acitretin is used. Acitretin, which we are usually using for psoriasis, is working also well and has a very high response rate. And so in my experience, if I use retinoid, just personally, to give you my personal experience, and since we have often older patients, I prefer acitretin over bexarotene because it's regarding the side effect is much safer than the bexarotene. And if you want to compare, the effect of interferon and acitretin, we have one study, and you see higher response rate with interferon combined with PUVA than retinoid with PUVA. But you have to choose the systemic drug, of course, regarding the patient age and also about his other concurrent diseases. And at the end, as promised, I want to show you the role of total skin electron beam, which is a very effective treatment and which I estimate very much. When I started dermatology 25 years ago, usually it was used the high dose total skin electron beam. High dose means something between 30 to 45 gray. And the patients I have seen, they're getting erosions, ulcers, so a lot of side effects. And the first patient I have seen, he got a severe infection, sepsis due to this ulcer and died of this. And I forgot this total skin electron beam. However, in the last years, we have a lot of data using it with a low dose, so only of 12 gray, or lower than 12 gray, like 8 gray, and it works very well. It's very easy to do. And here I want to show you a study from London, from Steve Morris, who used this total skin electron beam. You see the Stanford scheme. It works very superficial, between 2.5 to 1 centimeter. And you can reach all parts of the skin, and also for the hands and for the legs. You see the response rate is very high. And you see, if you combine it regarding the side effects, in the low dose, 12 gray in the red, we have very rare these adverse events like fatigue, leg edema, dermatitis, or blisters, compared to the high dose of 30 gray. And here you see from the study in the early stage 1B, complete remission after 12 gray. So what does it mean, 12 gray? It means usually that you give the radiation 6 times for 2 gray. So after 6 days, you are ready with the treatment and have already a good response. And regarding to this study, if you look to the early stage 1B, the response rate is about 94%.
Dr. Assaf.
And here my last slides. You see here an example. That works very well. And you can use it only to also in 8 gray, so twice of radiation with good results. And the hypothesis is also that it can eradicate, here in the Stanford data, the tumor cell, which could use also to the healing of the patient. So my take-home message, patients with early stage usually have a benign and chronic disease course. Skin-directed therapy like PUVA are the treatment of choice. Clomitingil is a novel alternative as a mono or combination therapy. In refractory or progressive cases, you can combine it with skin-directed therapy like interferon or retinoids. The choice of systemic therapy depends on toxicities. And at the end, I showed you that low-dose total skin electron beam is an alternative also in the early stage. And by this, I thank you very much for your attention and open for questions. Thank you.